Good morning, everyone. Very warm welcome to everyone today to our 14th Medela Breastfeeding and Lactation press conference. It's great to see you all here today. It's great to see our speakers. A very warm welcome to our speakers who have travelled, some have travelled far and wide, some got here on foot or so we've got a very good mix of speakers, and so it's great to see you all here today. Before we get started, just some opening comments, and that this is a really important event on our calendar, on the Medela calendar. And we want to try and get that information and the information that exists in our speakers out to yourselves in the press world and also online. Before we get into the full presentation, however, what I would like to do is ask Annette Bruls, the CEO of Medela AG, to come up and give some few opening comments and to welcome everyone. Please welcome Annette.
Okay. So good morning, everyone, and good morning to our esteemed speakers as well. So for us, it's a great pleasure to be hosting our 14th International Breastfeeding and Lactation Symposium. This is a big tradition at Medela, as Leon just said. And for us, it's really, really important because we are a believer in the benefits, in the life-giving benefits of mother's milk for moms and babies. And we want to be the leading advocate and partners for mother's milk. And this is really important for us to drive this through science, collecting the right evidence, but then also making sure that this evidence gets disseminated to our healthcare professionals worldwide so that everybody understands the value of human milk, but also understands what it takes to implement this in clinical practice. And so it's really these two elements that we are bringing together over the next 2 days, sharing new evidence, new insights, but also speaking about how to put it in practice so that we can actually improve outcomes. And these outcomes, despite the overwhelming evidence on the clinical benefits for both moms and babies, as well as the health economic benefits, we still see today that maybe in the UK, a bit more than a third of babies are still breastfed after 6 months, despite the clear recommendation of the WHO to have up to 6 months of exclusive breastfeeding. So a lot of work needs to be done on the science, on education, but then also on partnerships with moms. How do we support moms to be successful in her breastfeeding journey? It's all these elements that we're going to discuss with the right stakeholders, healthcare professionals, advocates, moms, everybody together over the next 2 days so that we can truly improve these numbers, improve outcomes, and provide the life-giving benefits of mother's milk to all babies globally. So with that, I would like to turn over again to Leon, and who will guide you through this press conference. And welcome again to all of you, and welcome to our esteemed speakers.
Thanks very much, Annette. And that's a really good starting point for what this meeting is all about. And the speakers that we have for you today, they're here for a very clear reason. Their passion, they wear that on their sleeves. It's encouraging to see members of the press here as well. And I think sometimes from a breastfeeding and lactation perspective and an advocacy perspective, it's hard to, or it's easy to lose sight of breastfeeding and lactation because they're almost hiding in plain sight. But the newsworthiness, I suppose, for yourselves in the press is that the story of lactation and the story of breastfeeding is really the greatest public health initiative that you've never heard of. And it's really quite remarkable. And that led to those statistics from the UK in particular. So we're talking like 34% of kids under 6 months being breastfed, 1% being exclusively breastfed. The previous stat was for any breastfeeding. Now, we can keep on talking about statistics, and the UK ones are not unique. They're probably just maybe at the lower end of the spectrum, but there is a tremendous opportunity for us to improve that storyline. And we can do it the old-fashioned way, which is just to continually talk about statistics, but it's quite obvious that that doesn't change the outcome. what we need to do instead is, as organisations like ours, if we want mums to provide more milk for their babies for longer, we need to curate more of an advocacy platform for them. We need to promote, support and enable. And these 3 pillars of advocacy are areas that these speakers here all address. And that's how we build this symposium and deliver that message to yourselves in the audience and into the press. And so with that, what I would like to do is go through the procedure for today. And what we'll ask is each one of our speakers will provide a 5-minute summary of their research that they'll be presenting at the main conference over the next day and a half. I guarantee you we will have to ask them to stop. 5 minutes will not be enough. But I'd like for you to jot your questions down as they're going along, and what we'll do is that we'll open up, once we've heard from each one of our speakers, we'll open up to a question and answer session where you can target questions at individual speakers, or you can look to see if you can build a panel discussion as well through your queries of our speakers. Take this opportunity because these are the world's leading experts in lactation and breastfeeding, and to get them all in the same place at the same time is really a good opportunity and a unique experience. And so while I'll just quickly introduce the speakers in a row. We have Dr. Jacqueline Kent from the University of Western Australia. We have Professor Kevin Nicholas from Monash in Melbourne. We have Melinda Boss from the University of Western Australia as well. Professor Subhash Pokhrel from Brunel University. Dr. Daniel Mundblit from Sechenov in Moscow. Donna Geddes from the University of Western Australia. And Professor Diane Spatz from Children's Hospital of Philadelphia. And so with that, Jackie, I'll ask if you can please kick us off and give us a summary of the work that you'll be presenting later on today at the symposium, and just go through some of the key main areas for us, please. Thank you. Yes, you do.
Okay, is that better? Thank you very much. Good morning, everyone. Now, one of the most important things that a mother needs to have to breastfeed successfully is confidence, self-confidence that her breastfeeding is going to go well. And how do we give confidence in a biological function for some people? Now, if you're worried about your blood pressure, you go to the doctor and the doctor looks you up and down and you say, "Doctor, is my blood pressure okay?" And the doctor won't say yes or no. The doctor will measure, put a cuff around, measure your blood pressure. So, doctor, is my breastfeeding okay? Maybe. Is your baby growing well? Yes. Is your baby producing wet nappies? Yes. Is your baby reasonably alert? Yes. So is your baby fairly satisfied after breastfeeds? Yes. Good, you should be confident. Yes, okay, but aren't you going to measure anything? Well, what we do is we measure, because it's the best way to give someone confidence is to give them a number. So what we do is we lend baby weigh scales, properly calibrated, sensitive, integrating baby weigh scales to mothers to take home and to measure their milk production by weighing their fully clothed baby before and after every breastfeed for 24 hours. Because we know that the old situation where nurse would say, "Come into my office, weigh your baby, feed your baby, and I'm watching you, and then weigh your baby again," mother's going to lose confidence, she's not going to have a letdown, that's not going to be a typical breastfeed. So weighing your baby at home for 24 hours gives you an objective measure of your milk production. Not just your milk production, but how often your baby is feeding, how long your baby is feeding for, how much is transferred for each feed, and how much is transferred for the whole day. So you then have some numbers, but is this what the baby is supposed to be doing? There's at the moment no established reference range. So when you get your blood pressure measured there's an established reference range. The doctor will look and say, yes, you're within the range or you're not. If you're within the range, be confident everything's fine. If you're not, we need to do something about it. So with breastfeeding, what is the reference range? We're still working on collecting enough data to make absolutely sure what the reference range is. But what we've found is that the reference range is going to be very wide. So if you look at the books, they'll say the baby should feed 8 times a day, the baby should be on the breast for 15 minutes each time, and the baby should get 750 mils a day. But that is the average baby. That doesn't explain the range. Babies are individuals just as we are individuals. So what we need to do is say, okay, are you within the range or not? And what we've found is that there are some babies who will go to the breast for breastfeeding sessions 5 times a day, and they have an adequate intake. There are others who go to the breast for breastfeeding sessions 13 times a day. They have an adequate intake. Now, the one who feeds 5 times a day and has a happy baby doesn't need to feed her baby more often. The one who feeds 13 times a day doesn't need to feed her baby any less. That's just the difference between the babies. Some babies will take a meal each time and then be happy for a long time. Some babies are grazers, same as adults. Some will take 3 meals a day, others will be snacking all day. And they will get the same amount, they will get the adequate amount. But also an adequate amount is not 750 mils a day, and you have to achieve that. If you look at the World Health Organization growth charts, there's a range. Some babies are growing on the 3rd centile, the 5th centile, some are growing on the 95th centile, the 97th centile. And we're happy with that. As long as they're growing steadily, we're happy with that. So babies shouldn't have to have the set amount of milk. They can take the amount that they need, and they will determine, if everything else is going well, they will determine what they need, how often they want to feed, how long they want to be at the breast for, and the mother should be confident with that as long as she has measured it. Well, if the baby's growing well, she hasn't got any problems, she's confident, no problems. If she's lacking in confidence, she can do a measurement, she can compare with the normal range, and then she can either be reassured, or if she's outside the normal range, then she needs to be referred for some specialist treatment. So that's what I'll be talking about. I'll be happy to take questions afterwards. Thank you.
Thank you very much, Dr. Kent. I think that's an excellent start, and for us, a brilliant place to start is at the beginning. And so with breastfeeding and the understanding the statistics and how to help mums and how to explain that, and also to work with the medical profession to provide those statistics and that opportunity for the medical profession to bring and lift breastfeeding into a real discipline. I think it's a really important area, and it adds value and it adds weight to the whole process. If we're going to start at the very beginning, then there's a good opportunity to introduce Professor Kevin Nicholas, because his research really does look at the very beginning and understanding of human milk, and but in a very unique and creative way of doing so. Professor Nicholas.
Thanks, Leon. So our focus is really on trying to find better strategies for managing preterm babies in the NICU. So we know these babies present with very limited tissue development, particularly the gut, the lungs, the brain, and this poses enormous challenges for neonatologists in the NICU. So right now we know the best thing we can do for those babies is certainly to give them colostrum, but ultimately, of course, we want those babies to have human breast milk, whether it's provided by the mother or through a milk bank. So we now know that, in fact, mature milk is not adequate in terms of the nutritional plane that's required by those babies, so we need to add a fortifier to that to meet the nutritional requirements of these babies. But our focus is really looking beyond that, the nutritional aspect. We're looking for factors that we think may have a role in making those tissues in that preterm baby more functional more quickly. And to do that, we use a comparative approach. we work with a number of different models, but the one we work with predominantly is a marsupial, an Australian marsupial. It's a Tamil wallaby, basically a small kangaroo. And they're really interesting because they have a really short gestation, just 26 days. They give birth to a very immature altricial young. And then the mother progressively changes the composition of milk, and we know that's important for driving development of the young. And it's really quite fascinating because what the mother can do in the first 100 days, where we get a lot of development, is actually slow the growth of that animal, neonate. And while she does that, she sends in a whole lot of factors that we think are important for the way that young develops. And when the young becomes more independent, she then changes the nutritional components of milk to accelerate growth of the animal. So this is exactly what we want in the NICU. So the question is, can we take an understanding of that scenario, then move it across to the human situation and get perhaps some insights into how we may handle these preterm babies in the NICU. So we've done a lot of work in looking at the milk of the wallaby. We've found a number of factors in there that we think drives development, particularly the lungs, for example. I'll talk about that a little bit later today. So what we can do is to take that information, and we can use bioinformatics to move across the human and see where that activity lies. Is it preterm, for example, in being delivered by the placenta or perhaps the amniotic fluid, or is it being delivered in the colostrum or the milk? So we've got a sort of a continuum of signalling in the human, and we can look across that continuum to see where the bioactivity is that we're looking for. We really expected to see it preterm, but in fact, nature's thrown us a curveball in a sense, in that we're now finding certainly some activity preterm, delivered by placenta and amniotic fluid, but predominantly we're finding a lot of this activity being delivered in the colostrum and some in the milk. So now what we have is really a target which we can aim our arrows. So we're now suggesting that we need to reevaluate the role of colostrum. We all know that it's good, but the question is, do we know how good it is and why it's good? And they're the kinds of things we're trying to address now. So when we find those factors, we're hoping to build on the fortifiers that we're using now. So those fortifiers will include a nutritional component and an additional component. So they're going to be next generation fortifiers that will increase the functionality of those babies in the NICU. So that's the primary function of what we do.
Right, thank you very much, Professor Nicholas. And I think you will agree that this is a fascinating aspect of human milk and understanding the composition. And it really speaks to something which a lot of people don't appreciate to a degree, and that is that there's more to human milk than calories. There's more than just food. And that developmental aspect, and even that medicine, the food signal medicine concept of human milk, and in particular the strength that has for the very early young, and also from the colostrum aspect. So thank you very much. We will move back into the clinical world with Ms. Melinda Boss, who has really pulled together a tremendous amount of information into a very usable and pragmatic way. And so, Melinda, can you go ahead?
Yes, thanks, Leon. So I'm the founder and chief investigator for the Lacta Research Group, which is based at the University of Western Australia. And our aim is to support effective lactation through the translation of research to practice. If you look over the last 100 years, unlike other phases of reproduction, human lactation has declined in both initiation rates as well as sustained lactation rates. While we've been able to make some impact on lactation initiation, most women fail to sustain lactation for the minimum recommended durations. They're not abandoning breastfeeding lightly, and there are many reasons why this is the case. But our hypothesis is that compared to other organs in the human body, there's a comparative lack of basic research and a lack of translation of that research that is available to the medical care of problems with lactation. So over the past 10 years, a multidisciplinary group at the University of Western Australia, which I have led, has been involved in collating information to design an online tool which is called Lactamap. It's an online lactation care support system, and we've designed it specifically for the use of doctors. Doctors, obstetricians, paediatricians, and indeed many health professionals are all reporting that they're not receiving the education for the knowledge and skills expected of them when they're supporting problems with lactation. So that is why in the first version of Lactamap we have designed this tool to support their medical care. One of the first things we had to do was define normal function, because you can't determine what dysfunction is without an understanding of normal function. Then we defined our scope and created content for 112 clinical practice guidelines to support the medical care of problems with lactation. We also have supporting information, patient information documents, and normal function articles. These are all evidence-based. They're supported by more than 1,000 references. Because it's online, we have framework for continual content update and review, which means that we have a way to translate new research to practice soon after publication. The National Institute of Medicine did state that it currently takes about 17 years for research to be translated to practice, and we hope that with our online format we've developed a way to get research directly to practice. Lactamap's free to use. Anyone can access it anywhere in the world. And so we really hope that by creating this tool, making this information accessible to doctors when they're caring for problems with lactation, that we will be able to make some impact on sustained lactation rates. The wealth of content that's in Lactamap is also has the potential to be developed into education modules, both at the tertiary level for schools. The normal function articles can be translated into information that's useful for families. Many women struggle and they look for information about what's normal. Is this what's supposed to happen? And without the evidence base to support that information, it can be very, very difficult. So if you're interested, please register, hop on, have a look, and we're always open to feedback, critique, and information. So thank you.
Thanks very much. And again, that's an area of, from a clinical perspective, of bringing the physician back into the storyline, and it goes very clearly towards what Dr. Kent was talking about earlier as well, and providing them with the framework and with the professionalism associated with lactation that previously hasn't existed. And so Lactamap is a huge step in that direction, and one that has been a long time coming, but at the same time dearly and sorely needed. And so we'll move on now to our next speaker, Dr. Subhash Pokhrel, who, again, we're still in that public realm, in that public health realm, and the way he describes in his latest literature is how do people, mothers in particular, or if we come back to Melinda and Jacqueline, how do they make that decision? What is the trade-off in the decision, and what is the process of making that trade-off? And so this comes back almost to a health economic perspective, and Dr. Pokhrel has a very interesting take on that, and something which I think really helps us make those decisions and understand how they're made. So if I can please ask you to give us a summary of your work too, please.
Yeah, thank you, Leon. Good morning. The good news is that most women actually initiate breastfeeding. Even in the countries like UK, 8 out of 10 women initiate breastfeeding. That's pretty good. Not so good news, though, is that the breastfeeding choice actually drops significantly when it comes to 1 week or even 6 weeks. In the UK, we are one of the countries with the worst breastfeeding rates. Exclusive breastfeeding about 1% at 6 months. So why that happens? And from the economics point of view, it is very important to understand that suboptimal breastfeeding is creating a substantial amount of cost to the healthcare systems. Breastfeeding is protective, so if you just take some of the illnesses in infancy, for example, infections of the gut, lower respiratory tract, or the middle ear, and in preterm babies, a condition called NEC, where breastfeeding is protective. So that simply means if less and less women choose to breastfeed their babies, then there would be more cost to the NHS. And it is important to quantify that cost. And my work is to look at and quantify that cost for advocacy purposes, and also to understand that if we didn't have to spend that amount of money treating these preventable diseases, then we would be using that amount of money doing something else. And that is very important. Now, the second part of my work looks at some of the policy measures to mitigate that burden, economic burden, due to suboptimal breastfeeding. Say, for example, 8 out of 10 women in the UK choose to breastfeed at birth, and then it drops. What if we supported mothers who have chosen to breastfeed to continue for longer? So is there any economic benefit out of that? And it's not an unrealistic target. Say, if we maintain 80% breastfeeding rate at 1 week, is there any economic benefit out of that? And my second stream of work actually quantifies that. And we did a study in 2012 and looked at the evidence, and where the evidence was the strongest, and that was those 4 diseases I talked about earlier in infancy, and maternal breast cancer, where breastfeeding is protective. And just looking at those 5 conditions, we estimated that there would be about £40 million of savings to the NHS every year if we increased the breastfeeding rate in the UK at a moderate level. And that is simply, for example, supporting women who are breastfeeding at 6 weeks to continue until 4 months. And that's not an unrealistic target to achieve. And I'll be talking about that later in the afternoon.
Thank you very much. I think when you hear it like that, those numbers are staggering. And they really do make you pause, because you probably haven't heard that storyline pitched in that way before. And that comes back to a quote, which I'll probably paraphrase, from Mark Hansen, who was the VP for Human Development at the World Bank. In a paper that he wrote in 2016, he said that if breastfeeding didn't exist, someone who invented it today would deserve a dual Nobel Prize for medicine and economics. And our first 4 speakers today have really explained that brilliantly, I think, to show that that is just the power that human lactation and breastfeeding has, and it's not the dialogue that we're hearing. And so this is a way of changing that dialogue. And from an advocacy perspective, as I mentioned before, we're not focusing on just reiterating the poor statistics that you're talking about, but you're talking about where can they go and what can we do with them. And I think that's quite a powerful storyline. If we move on now, in the interest of time, and our next speaker, and our next couple of speakers, we're shifting the conversation in this instance away from the, let's say, the promotion. And so all of the clinical work and the work that you've heard so far is really directed towards promotion and policy to a degree. If we look at support, to provide the information to support mums in their decision to breastfeed, how can we do that? How can we add into the conversation for there? And then we're looking at, well, what is in breast milk and what does breast milk provide and convey to breastfeeding babies? And a part of that is to explore these unique components in human milk. And Professor Daniel Mumblett has done some excellent research in the immuno benefits. And again, we'll come back to what Professor Nicholas was talking about before, and that human milk is more than just a food. And so please, if I can ask Professor Mumblet to give us a summary of his research.
Alan, thank you very much. You know, when I meet with pediatricians or colleagues or fund givers, they normally say, everything is known about breastfeeding. Why do you need to do studies on human milk? Everything is well known, well established. That's one thing. And secondly, going to the supermarket and getting the can of the formula, infant formula, you see normally the claim, our closest to human milk. But it's not the case actually, because human milk is a very, very complex body fluid. It has oligosaccharides, fatty acids, different immunological markers. It has antibodies, cells. There's so many things in it. So just by taking one or two substances and adding them to infant formula doesn't mean that we got anywhere close to human milk complexity. So our work is mainly focused on breast milk immunology, so on cytokines, chemokines. And there are many questions to it. Number one is human milk different from one country to another? And actually nobody knows the answer, but probably it is. And we're getting more and more data, and some work that we've done as well with our collaborators from different countries shows that human milk in its immunological composition is very different from one country to another. Does it mean that at the end of the day, formula manufacturers will have to make formula specific for every country? We don't know. Because although we are breast milk researchers, we need to understand the consequences. And of course, our work will be picked up by the industry. That's inevitable. But our main interest is not to develop the industry, but to help the moms to prevent diseases, predominantly non-communicable diseases. So our goal is to understand breast milk immunology to the point that we will be able to influence human milk by different dietary interventions. And there's more and more data coming out showing that certain supplements like probiotics or fish oil may alter breast milk composition. Particularly when we're talking about immunological composition, it's very important because these small, tiny molecules are of an extreme importance to the baby immune system maturation throughout the very first months of life. So we are interested to find out which factors influence human milk composition and which factors within this human milk composition are related to immunological outcomes, predominantly non-communicable diseases, allergic diseases, food allergy, eczema, asthma. And then when we find out these crucial factors within breast milk, we want to boost them. We want to give some supplementary, we want to change the diet to boost the levels of these crucial markers. And by doing this, prevent non-communicable diseases. So that's what we're aiming for.
Thank you very much. Again, an extremely powerful line of research, and you can see the implications to public health, and just how vast and broad they are. And on that point, if we look at Professor Donna Geddes' work, now we're into the realm of the real hot topics of public health, and we're talking about obesity and body composition, and how does breast milk start that off with the infant, and what advantages are there, and what are we starting to learn from breastfeeding and in relationship to body composition and obesity. Professor Geddes?
Thanks, Leon. I'm really following a similar line to Daniel here. I gave Medela a topic some months ago, and my title is How Fat is Too Fat? And then I realised that perhaps I shouldn't be talking about how fat is too fat. However, obesity rates are rising. Our childhood obesity rates are going up in the UK and Australia. We know that childhood obesity predisposes those children to being obese later in life. Now, obesity is a risk factor for metabolic dysfunction, which has been linked to non-communicable diseases, particularly cardiovascular disease, diabetes and cancer, some of the major killers of premature deaths in our older population. Now, the incredible thing about breastfeeding is the meta-analyses still show, despite our diets nowadays, a 10 to 20% lowering of risk of obesity if you've been breastfed. So why is that? Why do we need to know? Well, we need to know because if we intervene, we may do more harm than good. So what is it about breast milk and breastfeeding that protects the baby? Well, we know that breastfed babies grow differently to formula-fed babies, but they grow rapidly in the first 6 months and then they slow down. So that period of exclusive breastfeeding is very different to formula feeding, and it's thought to be protective. However, we have this hypothesis in the literature that rapid weight gain is bad. It's linked to obesity later on. But our breastfed children are programmed to have better outcomes. So is it growth or is it modulation of body composition? So we have a severe lack of understanding of how that body composition develops through the first year of life in breastfeeding babies. So we set out to run a longitudinal cohort over 12 months of lactation. We recruited mothers and babies and we brought them in and we did a ton of measurements, right? So we're all about measuring in science. So we measured the baby's body composition, we measured the mother's body composition, and I tell you that was a bit tricky because we also weighed her, which is very invasive if you have to get on a set of scales in front of a whole lot of people. And then we told her how fat she was and counselled her that she'd just had a baby afterwards and not to be concerned about that. But we tracked that throughout the first 12 months. We tracked the baby, we looked at gastric emptying, which is involved in appetite regulation because we know our breastfed children regulate their appetite really well. Okay, so we were looking at that, and then we were looking at the components in the milk because they're special, they're different to formula, and they have dual properties. So they don't nourish the baby, they protect the baby, they build the immune system. So the unique thing about this study was too that we did 24-hour milk productions and 24-hour milk intake, as Jackie Kent has described to you. And we looked at the components that had previously been looked at before and new ones that have never been related to growth of the baby. But that's because they were looking at concentrations. Now, if babies take vastly different volumes of milk, it's the dose that matters. At least that's what we suspected. So we simply multiplied the concentration by the milk intake of the baby and we got the 24-hour dose, so we knew exactly how much the baby was getting. And lo and behold, several of the components, the doses related to their adiposity and to their lean mass, right? So for example, leptin, which I seem to lack for satiety, despite being breastfed, is present in human milk, right? It's barely present in formula and probably made non-active by the processing. So we've got biologically active leptin in the human milk, and what we found was that that was related to the fat mass and the lean tissue in the baby. So the mother was modulating through the dose of leptin how that body composition was being developed. Now, the interesting thing, it gets even more interesting because that was related to feeding frequency, which we could see on the milk productions, and subsequently the milk intake. So we have this beautiful system of how the breastfeeding behaviour is related to the component dose and then the growth and modulation of body composition. And it gets even cooler because what we found out was that the maternal body composition was related to the human milk leptin concentration. So Daniel's talking about modulating breast milk. we have now a window of intervention where we can perhaps encourage mothers to change their body composition pre-pregnancy, ideally, that will affect the amount of leptin in the milk, subsequently, hopefully getting better outcomes for the baby. Now, once we did that, we looked at all of the other components, and I'd just like to add, we looked at immune proteins, the major ones, and they are also related in dose to body composition. And that is likely through modulation of the immune system, not through nutrition. So it affects the microbiota of the gut, it affects intestinal permeability, and it also protects from infection, which allows our babies to grow at an optimal rate and form an optimal body composition. So you can tell I'm quite excited about that, and we've kicked off another number of cohorts and studies with dietary interventions to see if this is the better way to go. Because as I'll show later in the talk, how fat is too fat, those really fat babies, you know, the gorgeous ones that look like the Shar-Pei dogs with the rubber bands around the joints, they are considered, whether they are exclusively breastfed or not, to be rapidly gaining weight and therefore be at risk for later obesity. So I'll show you some data from our lab and a colleague's lab that we worked with that will hopefully convince you that intervening in this respect will do more harm than good. So I'll leave you with that tantalising little tidbit and hand it on to Leon.
Thanks very much, Donna. Can you see a pattern emerging now through our speakers? You know, we're looking at that promotion aspect, which is really looking at the societal level, the benefits and how to improve breastfeeding rates and in the society level. And then we're drilling down into, well, what does it mean to the individual? How do we support mums and babies with information that helps them make those decisions? And so we can see that with Daniel and Donna's work. But there's something critically missing here in this dialogue, and that is how do we shift that information into practice? How do we put that into the hands of people in a digestible, easy format that allows them and those healthcare professionals and yourselves to carry that information to those mums? We've seen that a little bit with the work that Melinda Boss is talking about, but who we do have is Professor Diane Spatz, and she has been able to really transfer that information into practice. And that evidence to practice link is critical in this whole advocacy storyline. And in fact, everything falls down if you don't have that. What I have noticed is over the course of the other presenters, Diane's been writing down the deficit in time that each presenter has used. And she is going to ask for their time as well. But please, Diane, can you give us a summary of your work?
Leon knows that I will talk as long as he'll let me. But thank you so much for having me here and inviting me, Leon. It's a pleasure to be here. I am from the United States, and many times people think about the United States as being one of the worst places for breastfeeding. We've caused maybe a lot of problems with the advent of formula industry. But actually, the U.S. is actually doing better than many countries, including Australia, exclusive at 6 months. So I'm going to open by talking about the fact that in the United States, we actually had a congressional task force formed about research specific to breastfeeding women and to pregnant women. And this is pretty amazing that we actually have a congressional task force examining this. Before I got on the plane to come here, I found out that our task force has been renewed. And what's really important about this is it has brought attention to the true lack of research that exists for both pregnant women and lactating women. And one of the really interesting things is when I started serving on this task force 2 years ago, they did not have the topic of milk supply on the agenda. And I said, well, how can we be talking about research specific to lactating women and not talk about milk supply? It's kind of hard to understand. And in fact, when we looked at a landscape view of a decade of research, we found that there were only 48 publications about milk supply in a decade, okay, from a research perspective. So clearly, we have real gaps in research. And then we have gaps on how that research gets then translated to clinical practice. And so my role as being both a university professor and a clinician and a nurse researcher working at Children's Hospital of Philadelphia is that translational research that Leon mentioned. So I will be talking about methods in ways that we can actually get the right messages out to moms when they are pregnant. For example, having the mother have confidence in her ability to make milk because she is making milk from 16 weeks of pregnancy forward. We have to then think about how do we empower her and her family to set them up so that mothers can reach their personal breastfeeding goals. We need to be aware of risk, okay, because both mothers and their infants can bring risk to the lactation experience that could impact milk supply. And we know globally, milk supply is the #1 concern. It doesn't matter if we're in the UK, Australia, Russia, America. That is the #1 concern of families all over the world. And so I'm going to be talking about strategies in that critical window of opportunity that ensure that mothers get off to the right start so that they can meet their personal breastfeeding goals. We're going to talk about risk, and we're going to talk about ways in which we can mitigate that risk and ensure that moms develop a complete milk supply and they have confidence, as Dr. Kemp mentioned, in their ability to breastfeed their children so that all women can provide that 100% human milk diet for the first 6 months and continue for a year or more, whatever their goal may be.
Wow. It's a new Diane. So, I mean, now you've heard from all of our speakers, and you can see the continuum that we're talking about from promote, support, and enable, and enabling clinicians and healthcare professionals to provide that support and that promotion to mums and babies in their care. So what we'll do now is that we'll open up for questions to the floor. You can ask your question to any one of our panellists, or you can direct a question for a couple of them to respond to. So any questions from the floor to begin with? Stunned silence. In the back, just wait for the microphone, we'll get to you in a second.
Professor Geddes, you're talking about babies starting off, breastfed babies starting off being lovely and chunky and fat, and then the programming of the composition of maternal milk, then changing that, signalling changes. At the moment, is there any kind of pattern of that, or any sort of charting? And at the same time, does that, in the same way as all the other speakers have said, does that vary crucially from woman to woman or to dyad to dyad?
How many questions was that? So
it's really, do we know, is there sort of, they start off fat and the signalling starts getting them slimmer?
For a start, breastfed babies grow more rapidly than formula-fed babies over 6 months, and then they slow down, and the formula-fed babies continue to grow rapidly. And part of the reason this rapid growth is considered bad for the baby is because it's based on formula-fed babies, who typically get more protein, which fuels more growth there. And we know breast milk is very low in protein. So the components appear to modulate that. Now that's variable in mothers, and we have variation in growth. So we have the centiles. One thing about our research is you'll see relationships between the fatness of the baby and the lean tissue There are relationships, and they will vary, the same relationship holds, but will vary across that spectrum. And we were talking about this last night, that we get these fatter babies, and we often discard genetics in the conversation. So part of that variability is due to the genetics of the baby. Now, the other thing about the body composition, our breastfed babies are fatter than formula-fed babies initially, and then the formula-fed babies are fatter than the breastfed babies in the second 6 months.
So it's over those 6 months that the switch starts to
So
flip.
over the first year, and the switch happens at 6 months.
Right.
Theoretically, that first 2 years is the critical period, but a lot of the studies only do 1 point of follow-up at 2 years. So the variability is quite wide. Now, people think being too fat is bad, right? But if you look at our babies, they're very immature, and they need fat to fuel their growing brains. I figure that's why they're smarter, right? So your brain is incredibly demanding of fuel, and the baby's brain grows from 30% of the adult size in 3 months to 60% of the adult size. There are differences in brain structure of this breastfeeding. That structure difference translates to cognitive differences, and in Brazil translates to more money at 30 years of age when you go to work. So yes, there's a large discrepancy between formula feeding and a very different trajectory for our babies in that first 12 months.
Okay, thank you. That's great. Thank you very much. We also have an online viewing presence for today, and we have a few questions that have come in from our online viewers, and Thomas is looking after these. Thomas, can you relay those questions?
Yes, thank you. Donna, there is a question relating to what you are saying. There is a question coming in saying, should we reassure mothers when even their little ones are too fat, that fat at the beginning is not bad?
So currently, from a scientific point of view, we have no evidence that a baby that's fully or exclusively breastfed that is above the 97th percentile is detrimental or linked to obesity later in life. So the alternative, so the study where we looked at babies that were very high weight, we called them, and compared them to normal weight babies, those babies had a rapid trajectory in the first year, and then they had a catch down back to the centiles once they started moving. Now, we don't know if that's detrimental, but the person that started this study was a neonatologist who was concerned and was thinking of telling these mothers to wean onto formula. Now, I just told you, if you start feeding formula, then you're going to change the baby's body composition dramatically. So I think we should be reassuring mothers, telling them there's no evidence. What's happening is they're getting a hard time from clinicians who link this to poor outcomes, but also their family and friends. So I think we can't intervene for fear of doing harm.
Thank you. Yeah, there's another question for Professor Mumblit. Are there any other specific allergy researches we should look into now?
Sorry?
Allergy researches.
Allergy researches with regards to human milk overall. Yeah, I would say that it's a very good question because so modulation is probably the primary interest at the moment because originally, a few decades ago, people were looking at a single cytokine in human milk, one by one. So you were reading the studies and you see that people measured interleukin-1, then they measured interleukin-10 and interleukin-2, etc., etc. So they measure them one by one. And then moving forward, we see that actually people doing completely different things now. We're trying to measure many cytokines. So we're not just looking at a single immunological marker, but we're looking at more than one, at 10, 15, 20. And then a combination, so not just immunological markers, but immunological markers and microbiome and polyunsaturated fatty acids. That's one of the interesting ways to look at the topic. So not trying to look at the single markers, but trying to define the human milk into lactotypes. You know, there are popular concepts of enterotypes, etc., etc. So those people who are obese and those who are lean, their microbiome is very different. And then you looking just at the patterns of their microbiome, you may predict whether they are lean or obese. Maybe we can do similar things to human milk, so we can find a particular lactotypes, a combinations of breast milk composition, which is linked to a protective effect with regards to a particular condition, particularly allergic diseases, because allergic diseases, we know the pathways which are involved in allergic diseases in both development and acute phase.
Yes,
questions from the
yes,
online
there's another one,
audience?
interesting one for Professor Niklas. The question is, are there other marsupials you could look into researching? Are there other marsupials you could look into researching? Maybe you want to explain, because in international audience, not everybody might know what is a marsupial. So
Well, that's a new one to me, actually. But yes, obviously the marsupials behave as a group of species, I suppose. And you know, we've chosen to work on the Tamil wallaby because we have a research colony. We know a lot about this animal in terms of its reproductive strategy. But we do wander across to Monodelphis domestica, which is the opossum, you know, the American marsupial, and we can get data that's relevant in opossums that links to the wallaby. But really, it's about the reproductive strategy that they have. They all share the same reproductive strategy, and it's a very short gestation, birth of a very immature young, a young that's not immune competent, which is interesting. And then this change in milk composition that we see that's so important for the development of that young. So that's consistent across all the marsupials we've looked at.
Any questions from the audience, the live audience in here? Just stand, the microphone will get to you in a sec.
Thank you. So, Donna, sorry. If a baby has lost, say, 10% of their birth weight on day 5 or up to day 7, they're then transferred back into hospital for top-ups. What are your thoughts on that? Should we be focusing on how that baby's thriving in regards to wet and dirty nappies and behaviour, or are we just focusing on weight loss?
Oh, man. That's a controversial question.
Isn't it? But sorry, I had to ask.
So you had to ask it, and I think Diane will weigh in on that later. So we and Jackie will show you milk production statistics collated over all of the papers, and certainly some of our early work, that suggests that full milk production should be achieved by 7 to 10 days. So at a week when a baby's losing weight, we would be very concerned about the mother's milk supply and boosting that as quickly and effectively as possible. In terms of whether you can wait longer than that, you know, that's a period of rapid growth as well. I think I'd defer that controversial question to Diane because she has much more experience with it.
Thank you, because you know I want to talk about this.
I know
So this is a real problem in the United States and many countries in the world where, I mean, I personally don't think we should be weighing babies at all. We should weigh them at birth and wait until they're 7 days. We know babies lose weight. I am a mentor of a PhD nurse in the U.S. who's doing research looking at neonatal weight loss. And in her research, she found that over 50% of babies lost more than 7% of weight, which led to the top off, which led to a delay in lactogenesis 2, which led to breastfeeding cessation, right? And so one of the ways we have to really think about this is how women are giving birth, okay? So most places in the world, women are not giving birth with no IVs. They're not giving birth without anesthesia. They're not giving birth without Pitocin. So they have very interventional deliveries, which exposes both the mother and the infant to IV fluid. Weight loss occurs after IV fluid exposure. We know this from many research studies. But also, the way in which women are giving birth also affects infants' breastfeeding behavior. So then the baby isn't feeding well, right? And then it becomes this very rapid downward cycle. And we really, in that really critical window of period, we can destroy the breastfeeding relationship. And so I'll talk about this in my talk tomorrow as well. You know, we have a critical window to really effectively establish milk supply, right? The first 3 to 5 days. And if we muck it up in the first 3 to 5 days, we muck it up forever. And so I do worry about this question a lot. And one of the things we see in America is people are looking at, for example, avoiding formula, which is a good thing. So they're looking at using, for example, pasteurized donor milk to top off babies, even term babies. But the problem is, if you're topping off the baby, but you're not addressing mom's milk supply, then you're not solving the problem. So I always talk to both clinicians, healthcare providers, and mothers that if anyone's ever going to say the S word, supplement, that's what we call it in the US, you have to say the P word, pump, right, with a hospital grade pump. So you can't tell a mom to top off her baby or supplement the baby unless you're going to tell her to initiate pumping with a hospital grade pump. Because for some reason the baby's not feeding effectively or transferring milk effectively. And if we don't address this in terms of milk supply, we're not going to have a breastfeeding mom.
Thank you.
Melinda, go ahead, Melinda.
I was just wondering if I could add to that as well. It's really interesting with human lactation in that we medically support pregnancy and childbirth, but lactation is often considered to be an optional extra. Interventions that happen around childbirth, as Diane said, can be risk factors for lactation. And there are actually quite simple things that we can do to monitor these women and have a plan in place to try and reduce the adverse effects on lactation of these things, like analgesia. Babies instinctively know how to breastfeed. They have reflexes. Mums have to learn. Infants that are, and I better actually also make the point that I'm not saying we shouldn't medically intervene to support pregnancy and childbirth. I think it's fairly unequivocal that medical interventions have reduced mortality around childbirth. However, we need to then follow through and support when things have happened that might be a risk to lactation. So the analgesic example, mothers who have been given analgesia during childbirth, that reaches the infant through the placenta, and it can affect their instinctive reflexes to breastfeed. It might affect their latch to the breast. Mum's under the influence of analgesia, so she's not feeling that latch isn't quite right, so she can get damaged with the first breastfeed, and a whole cascade of things that happen. So we need to have this information, and that's where we're all trying to sort of slot these things together, where you can have this understanding of what is normal function, when has something outside of normal function happened, and then have these strategies right from the beginning to support normal function and hopefully improve lactation.
Yeah, exactly. So we should be risk assessing
Yes,
at birth effectively, and then putting a plan in place rather than trying to deal with the consequences of the problem, which are...
Yes.
Yeah, okay.
May I just add, I also, though, think we need to do some of this risk assessment before the mother ever delivers, because There are many, many conditions that we can identify antenatally. Being a first-time mom, being over age 30, having a BMI of over 30, right? These are all things we can identify before a woman delivers. And so that's not saying that you're going to then like scare the woman that breastfeeding's not going to work, but you're going to set that woman up with a different plan to manage her lactation so that she has an outcome, so that she can meet her personal goals. Right before I came here, I just worked with one of my colleagues who was 42 years old, having her first baby, a history of infertility, a high BMI of over 30, and, she ended up, of course, with a cesarean birth, right? And so, but one of the things I said to her is, I said, Nala, you need to rent a Symphony pump and take it to the birth hospital with you, because you don't want to rely and wait on whether or not the hospital's going to choose to bring you a pump or not. And in fact, that's what she did. And she, all the people at the birth hospital were looking at her like she was kind of, what's wrong with you? But the thing is, she effectively converted from lactogenesis 1 to lactogenesis 2, despite her risks, and was able to go on and, 100% exclusively give that baby nothing but her milk. And, but it's that proactive management, and there's so much we can identify before a woman even delivers.
Yeah. Brilliant, thank you.
Yeah, that fired him up a little bit, that question. That was but I think the passion in the answers to that complex question really indicates the elevation of this storyline into a clinical practice and the standardization of that clinical practice. And so it's not left up to each individual at each hospital, each champion at each hospital or each facility to work out the best care plan based on their experience or based on their reading. The idea of elevating this to standardized practice is something that is really quite critical, and Diane is a great example of that. If you go to Children's Hospital of Philadelphia, you can see the protocols that are in place. The nursing curriculum is based around it, and you see all those care plans. And so to take that information into a standardized care practice is actually the key step in the enablement process, and so it doesn't become a haphazard process as well. And you see it link in to the things that Melinda's talking about as well. And so that planning, and it becomes something that is proactive in the planning of the mum's breastfeeding. And so she is really focused on that, and there is a plan for it that is tailor-made based on cold, hard evidence and good outcomes. And so if we want to get more mums producing more milk for longer, then the standardisation of practice and the standardisation of care is a really critical step in that process. Thomas, was another online question?
There's a more general question, but it's directed to Dr. Pocrell, but maybe others have also a view on this. To which degree do you think today's lifestyle aspects impact low or bad breastfeeding rates?
Right, that's a very good question. As you know, breastfeeding is a lifestyle choice. And breastfeeding also is a behavioral choice. And from that point of view, breastfeeding, we cannot look at breastfeeding choice in isolation. There are lots of other things going around in women's life, the individual characteristics, but also the social capital around the woman. For example, whether or not there is enough support from friends and families. Have we got the legislative environment that is conducive for breastfeeding? Those sort of environment is very important, and these choices are made within that context. And one of the things that we economists like to do is saying there's nothing such as a free lunch, and breastfeeding can be expensive if you're not very careful. It's time cost, and also it's a monetary cost. There was a 2004 study that showed that if you're not careful, then you tend to buy a lot of stuff that is you think is needed to breastfeed. Actually, you don't. And therefore, you end up spending a lot of money, and it kind of turns out to be more expensive than formula feeding. But the reality is that most of these expenses are not needed in the first place in order to breastfeed, and those kind of messes are not there. And that brings back the question about, do we have got enough support around women in relation to providing information, in relation to providing other sorts of support? And that's what makes the huge difference. So I think it is a choice the women make, okay? And the good news, as I said, that most women actually want to breastfeed, and majority of women have told us that they stopped not at the time they'd like to. They wanted to breastfeed for longer and for exclusively, but they didn't feel there was enough support around it. So I think it's a complicated behavioral choice that women make, and we need to look at all those contexts very carefully.
And if I may add as well, we did a study here in London, published last year, looking at midwifery support and opinion and influence on breastfeeding and formula top-up. I was in one of the central London hospitals, and despite all midwives being taught, so it's a baby-friendly initiative, so all midwives being trained, all of them, they're really keen to support the mothers. Many failed. Why? Because the hospital is understaffed and they don't have enough time to support the mothers. They really want, but they can't. Also, despite all the training, when we gave clinical scenarios to midwives asking, would you top up this baby? In more than 90%, midwives failed to recognize the right scenarios to, clinically relevant scenarios to top up. So in many cases, mothers are provided, so babies are provided infant formula with absolutely no clinical relevance. But that's what happened because mothers are tired, this is their first baby, they don't know what to do, they ask for help, midwives are absolutely facilities are understaffed, midwives are extremely tired, and they give a go, but they give up quite quickly. So, and I think that this is also related to the maternal choice at the end of the day. So, and this is one of the major issues, I think, here in Britain, when I can compare it to Russia. We have problems in Russia in this sense as well. But I think one of the major issues in the UK is that management overall doesn't realize how much of a difference can breastfeeding support to the mothers and the families and the babies, of course.
I'm dying to make a comment. I did also want to just push back a little bit on the choice because lactation is part of the reproductive cycle. Women have a right to expect normal function, and this isn't, mostly it's not happening. There are many reasons why. Social pressures against breastfeeding in public being one of them, the fact that we need to learn how to breastfeed by observing other women. But I think that it's really important to point out as well that if women's expectations of lactation fail to be met after birth, they grieve as well. It's not just a choice, it's a biologic function as well that we should be supporting. Thank you.
Diane?
So, thank you, Melinda. I 100% agree because I don't think the way in which midwives or nurses or physicians, the information they're getting currently, I don't think it's the right information. And there's a publication by the World Health Organization that actually caused them to question whether or not the baby-friendly hospital initiative actually makes a difference. or that it actually works. And so one then has to think about what messages are being sent and how people are being educated or trained or supported if we don't have great evidence. And I do know that we have models that are published that actually do work, that ensure that mothers and their families make informed feeding choices, because most women don't really make informed feeding choices. They make them based on their social environment or their social context. And then it's kind of creating this environment where that woman has the opportunity. And so I'm just going to give an example of return to work. Return to work is always cited as a reason that women can't breastfeed or can't continue to breastfeed. And this is where in the US, we're actually stellar compared to many places in the rest of the world. Our women do have to go back to work early, but we have corporate lactation programs. We've done research at Children's Hospital of Philadelphia, and we have 80% of our mothers breastfeeding at 6 months, and we have 20% of our mothers breastfeeding over a year. And so when you think about this from an economy standpoint, I mean, there are solutions out there that are published that do work, that also can be scaled up. But how do we get those opportunities to all women all over the world? I think that's a really important question, because we're not going to have paid maternity leave all over the world for 6 months or for a full year. And women are going to have to breastfeed in the context of their community. And so how do we create those environments where we have the social support and the support even if mother has to go back to work or school?
Thank you, Diane, and for the panelists for that question. Any more questions from the yes?
Thank you. Thanks, Melinda. The Lactimap sounds very exciting as a development, and often a lot of new mums are going to the doctor quite a lot for all kinds of things, vaccinations and whatever. What have you found so far is in a way, the most asked, the biggest issue that doctors are people are coming to doctors with?
Super difficult question. Lactimap launched last week. We don't have any data on how they're actually using it. We have some sort of population data, as Diane said, concerns about the efficacy of their milk synthesis. Are they producing enough milk for their infants is a common one. Pain is another very common one. It's also been part of our challenge when we're assessing the literature around breastfeeding is that studies that are done on populations, particularly high-income countries, are done on populations where you can't really say that breastfeeding is functioning normally. So, for example, pain is so common now that there are reports that women are being told that that's normal. Now, if we look at the evidence, we know that nipple sensitivity increases shortly after birth. We think that that's possibly due, from a biological point of view, the theory is that helps mothers behaviourally adapt to appropriate latch of the infant to the breast. However, prolonged pain that causes the mother to seek help for it cannot be considered to be normal. Pain is one of the body's mechanisms to get a person to avoid that activity. So again, that's an issue. I've deviated a little bit away from your question, but I think time will tell. We do hope to continue to do research around Lactimap and outcomes. I guess time will tell how that pans out. Thank you.
How are we going from the audience? Have we exhausted our questions from the audience? Another one at the front? Yeah, we have a little bit more time left, so you're okay.
Just a quick question to anyone and everyone, really. Would you recommend that all women express antenatally?
Let's start down this end.
So antenatal expression of colostrum is a really interesting concept. I don't think we have the literature to support that for all women to do at this point of time.
So you don't think it's safe for all women? Because we recommend it for women with diabetes and GDM.
So the Dayton study from Australia I mean, is the one instance where we have some data looking at women with diabetes and antenatal expression. What I worry about is, for example, in the US, there are clinical practice guidelines about antenatal expression of colostrum that aren't based on any available research. And so they have things like start expressing milk at 34 weeks of pregnancy, which hasn't been done in the research literature. So I kind of worry because women will just, get on their phone, Google, and it's like, okay, well, I'm just going to start expressing milk. And I do worry because I don't think we have adequate research at this point.
Okay.
And,
Sorry. Can I add, I'm probably sharing a little bit too much right now, but being in a scientific lab when I got pregnant at 42, people lined up at my door with pipettes while I was pregnant, and I could barely express a drop.
Mm-hmm. Yeah.
Now that is going to be devastating for women that are told, and this is happening for us too, that it will improve their breastfeeding, of which the DAME study has shown emphatically that it does not. And, milk supply initiates because of the drop in progesterone. That's going to happen. So any amount of expressing prior to birth is not going to hasten initiation of lactation. So we risk, and I talked about doing harm, is if women can't express milk during pregnancy, what do you think they're being set up to expect? And so that we're quite critical on that, but I think we have to be very careful about what the expectations are around those kind of practices.
Was that the DAME study? You said, yeah, okay. Thank you. Thanks.
Any other queries or questions?
What I was going to say.
Oh, Melinda, do you have? Were you? Okay, fair enough. I do have one question just for me, and because I'm holding the microphone, so I get to have the last word. No, my question is for Professor Nicholas, where we look at colostrum, and we have this idea, and it's been popularised a little bit by Katie Hinder as food signal medicine. When you're looking at colostrum and you're looking at those three categories, and maybe let's leave food out because we've said that colostrum and human milk is more than that. Medicine or signal, which of these areas are floating to the surface in the work that you're doing so far as the components that you're looking at? Are they more signalling components or are they more medicine components?
It's a little hard to break the two apart, to be frank, but I guess we're most focused on signalling, and as I said, we've looked in the marsupial to find those molecules that signal. Because we get a lot of postnatal development, it's easier to find them, and so we can relatively easily go back to the human, and as I said earlier, find out where those signals are expressed in this continuum of signalling, and we find that in fact they're present largely in the colostrum. And really this kind of makes sense really if you're interested in the evolution of lactation, because eutherians, women of course, are the only species that make colostrum. And I think it kind of makes sense in that what we're starting to see is a movement of signalling from the milk of the marsupial across to the colostrum. And I think it's kind of on the way to a scenario where we're going to see more signalling occurring during gestation. I think we're probably about 50 million years ahead of our time at the moment. And one could argue, I think, that 50 million years ahead as evolution moves forward, we will lose colostrum, we won't see it. Now that's a big call. I guess we won't be around to test it. But I think the short answer, Leon, is that we're most focused on signalling, and we're most interested in finding signals that drive the development of specific tissues or organs. And we think we can see those in the wallaby or the marsupial, and as I said, we can now go back and find them and see where they're expressed in the human.
Thank you. Very clear. That's personally extremely fascinating research from my side. How are we going from the audience? Any last questions? You will have access to the speakers over the course of the next day and a half, don't forget. They will be giving their full presentations over the course of the agenda. As you can see, they all like to talk. They're very approachable people. If you can find them and pin them down in the corridors or over the tea and lunch breaks, please do so. Because I think there is just a wealth of knowledge for you to access today. And it really comes back to that idea that we started about, from an advocacy perspective, and how do we change the dialogue just from discussion about statistics, these stats are good, these stats are bad, and how do we move that forward into actual action that is going to improve the outcomes for breastfeeding mums and babies. And we've seen with the panel today, we've got the full spectrum. You've got the promotion, you've got the support, and Diane is more than enough to carry the enablement phase on her own shoulders. And that that is a critical aspect for us and what this whole event is all about. So with that, I would like to close the event. I would very much like for our audience to provide our speakers with a warm round of applause. I think they've done perfectly today. Thank you very much from my side. Thank you very much for all the organisation here. It's a tremendous number of things need to come together for an event like this, and it's greatly appreciative, and also for our audience members. And the curly questions are the best ones. You should put them forward at the beginning. But thank you very much. Please enjoy the rest of the symposium. We look forward to your participation. Thank you.